Welcome back to the Relay, sponsored by the National Transitions of Care Coalition. I'm your host, Val Emmons, and today we'll be diving into one of the most critical yet overlooked pillars of patient safety: pharmacy, medication management, and the role a pharmacist play in healthcare transitions. From hospital to home, from Medicare Part D to open enrollment, and even the emerging impact of AI, pharmacists are on the front lines, helping patients understand their medications, avoiding preventable harm, and navigating an increasingly complex system. Joining me is Dr. Trisha Cash, PharmD, from Frederick Health Hospital. She works directly inside primary care practices, guiding Medicare patients through medication changes, cost issues, and Part D decisions that can make or break their care plans. This episode unpacks what's working, what's not, and why pharmacists must integrate more deeply into the care team. Let's get into it. Hey everyone, welcome to the Relay. My guest today is Trisha Cash, PharmD. Trisha, for listeners who may not be familiar, can you tell us about your role at Frederick Health Hospital and within the Frederick Integrated Health Network?
Yes, I have a very interesting role in that I am embedded in primary care practices through a collaboration with the state of Maryland, a grant. I call it a grant. I don't know if that's the technical term, but we work with primary care practices that are not affiliated with our hospital through an ACO agreement. And so I'm embedded in primary care practices to work with Medicare patients exclusively and helping them when they transition from hospital to home, to help them with any concerns they have once they're in the community, to help them with medication management, whether it be minimizing their medications, helping them afford their medications, helping them obtain their medications in any way, shape, or form. One of the best things about my position is that I work in tandem with nurses that are case managers and also social workers. So when there's transportation issues or they need a different level of care, maybe they need skilled care or assisted living, we have other people that can kind of help with those kind of activities as well. So we work really closely together to make sure patients in the community are optimally cared for and have a less chance of going back to the hospital and are able to, age in place as long as possible.
And how does your work bridge both inpatient care and primary care settings?
So that's a big part of my position, is that we have a standing listing of who is in the hospital. And so when patients are discharged, within a couple days, the care manager will typically reach out and make sure everything is okay, that there aren't any concerns with when someone goes home. And then I, in turn, will follow up with a call to make sure that all medication management services have been taken care of and make sure there wasn't any barriers in obtaining medications at discharge. And we also do that when they leave nursing home care. There's a little bit of a problem with that, a little more, because the communication between the long-term care facilities and our practices are not quite as solid. But that it would be one of the main ways that I work with patients. And then, as I mentioned, if they have to go to a higher level care from the community, then I work in tandem with the case manager to help with that placement. I don't do that
Oh,
myself, but the case manager does. Yeah.
oh, gotcha. So when patients are transitioned out of the hospital, what are the most common challenges you see when it comes to medication management?
A lot of times there's a lack of, and it's gotten better. It waxes and wanes, to be honest. Our county only has one hospital, so it kind of has a benefit more so than some other places maybe in the country, and that communication may be a little bit easier. We do work with outlying counties as well that have obviously their own hospitals too, so we do get information from there. But sometimes patients are not aware of changes to make to their medications, or they may know that a medication's been added, but not know that they're supposed to stop another one. So just that basic communication on this is what they want you to be on now is really important. Following up with the provider is critical because that's who they have the relationship is, that primary care provider. And I've seen oftentimes when patients will have a whole different list of medications, especially if they've been at a long-term care facility, had changes in the hospital, then had changes at the long-term care facility, and hadn't had really good communication on why those changes happened. And they go home with a totally different list and are confused confused on why that's going on and go back to their original regimen. So having that communication, I help bridge that as well as make sure that that primary care provider is tied into a visit so they can communicate the changes and why those changes happen. So really just the communication piece and making sure patients are made aware of why things are happening, I think is one of the biggest things.
I think
Cost
that
can be an issue as well. More and more, at least our hospital system they have a outpatient pharmacy that has started up in the last couple years, and they have been very good about assessing that and making that known to the patients. So they oftentimes know that. And since we're part of the hospital system, they'll tie us in too if there is an issue with cost of medications.
I think communications has been one of the most trending things that people say the problems are, which we know that anyway.
Yes, yes.
So with Medicare Part D, like we know that it's going to look very different in 2026. So what are the biggest changes patients and providers should be preparing for when you talk about costs and them not knowing what it's going to cost? So let's talk about that a little bit.
Okay. I did a little research in preparation for this podcast, and I did not remember that Medicare launched in 2006. In 2007, when they had the most companies that were participating in Medicare, there were 50 companies, and some of those companies would have 2 or 3 plans that a patient could choose from. Now, the average, of course, varies from area to area, but I listened to one podcast that said that the average is like 9 different plans that are available within that a patient has to choose from now.
Yeah, there's a lot. That makes it a little confusing.
Yes, it is a lot, but they used to have the choice of 50, so it's gone down a whole lot, but it still can be very confusing, and there's only really 5 big national companies that are part of it. For instance, Humana is still providing Medicare Part D prescription insurance, and there's 3 plans within our area that they can choose from. So even choosing between those 3 plans can be really important from a cost perspective. What a lot of people don't understand is that, last year was the first time when there was a cap or had the cap of $2,000 that would be the maximum that they would pay for their medications. But that only includes medications that are on the formulary of that prescription plan. So patients need to make sure that the medication is actually covered by their plan when they choose the plan they want for the year.
So from my perspective, you go all your life, you work all your life, and then you get on this Medicare plan and your medications might not be covered. And how long do you have to go like that?
So Medicare D is a traditional Medicare plan, and I don't want to go into the Advantage plans because they get really confusing. But Medicare D is you can look at your plan every year, and it's really important that you do because every plan changes a little bit. They change what drugs are covered, they change how much they pay, and they change the deductible. So just because it was a great plan this year, it may change totally for next year.
A whole year with if your medication you've been on for a while,
Yes,
so
if
you have
it's
to go
not
a
covered.
whole year before you can cover it and change it?
If they don't look at it every year, they need to change. Now, there are some circumstances where you can change. At least here in Maryland, if you go to a nursing home or you're hospitalized, you can opt to change your plan during that time if a big event like that has occurred. We have
Yeah,
a
but
state.
otherwise you're just gonna have to out of pocket it.
Yes. Yes, yes, and that's why it's so critical to make sure all your medicines are covered, especially the more expensive medications, of course.
And you still when you get older people, they don't my mom, she doesn't understand that.
No, no.
That's kind of a dirty little thing that they you know what I mean? Like, that's just a dirty little trick.
It can be, and insulin is a great example because, the insulin, the $35 insulin that came out a few years ago, that was taunted as being a wonderful thing for Medicare Part D, and it is, and, I mean, it's good that insulin should not be over $35, but they have to be on formulary, and last year they picked at least here in our state, that there was one insulin that had been covered that nobody covered, and so we had to switch everybody on their insulins.
Oh,
And
wow.
most doctors and most patients are okay, but I've had some endocrinologists that don't want to change therapies. And obviously, when you tweak different types of insulin, they may be both short-acting insulin or long-acting. They're different enough that you have to adjust, the amount of units that a person's taking. So it can be an adjustment time and can, and potentially be, detrimental to the patient.
Wow. So how do you anticipate these changes? How do you anticipate they will affect patient out-of-pocket costs and access to these medications. So what happens when they realize, okay, the enrollment period's over and
Right.
I've messed myself up?
Right. So what is required is that every insurance company must have a drug in a certain particular drug class. So as I was saying, there has to be a short acting insulin that's covered. So if their insulin isn't, and they need, cost is a big issue, and all these insulins are expensive. So in most people's case, that is true. Then they would have to switch to the short acting insulin that insurer had on their formulary and get a prescription from the prescriber. So if they don't know that, sometimes it's January and they go to fill their medicine and they realize that they may still have refills, but the insurance company won't cover it. So then they have to backtrack and talk to their provider and get the right insulin. And sometimes they don't have that knowledge to know why this is happening to them.
So
It
what
can be
role
confusing.
Yeah, sounds like. So, what role can pharmacists play in helping patients make informed decisions during this open enrollment period?
So I'm very fortunate that in my two practices, I'm in one 2 days a week and the other 3 days a week. I've done this for several years now. So I even, I have people that are calling me to set up appointments. So I sit down with them during open enrollment, look at their Medicare D plan through Medicare.gov, nothing real fancy, just the government site. We plug in all their medicines and look and see which ones are going to be covered. And then look and see if the plan they're on now is the most economical. And if not, what plan would be. Sometimes it may be $100 or less than $100 difference, and they just choose to stay with their plan because that's where they feel comfortable. But in past years, I've saved people thousands of dollars because certain medicines wouldn't be covered by a certain plan that they really did not want to change to another product, and we could go to a different plan, different insurer at that time.
So, I don't think a lot of people understand that that's something that a pharmacist can do for them. Like in
Yeah,
the open enrollment, they're just. I mean, usually, you go with your insurance provider and they can tell you, but I don't think that people realize you need to go to your pharmacist first if you take a lot of medication.
yeah, and I think that it's been, at least initially when Medicare came out, it was a conflict of interest for pharmacists to do this, especially retail pharmacists. Obviously, I don't dispense, and I am in the patient's best interest. I don't get any money from any of these insurers to push a Humana plan versus a Silver Script plan or whatever. And so, I am doing this in the best interest of the patient. So there aren't a lot of people like a pharmacist to do that, but there are definitely opportunities. And I think sometimes there are more and more pharmacists that are doing that. There is also a SHIP, and I meant to look this up before we met, but it is the state programs where at our Department of Aging, we have volunteers that go in and do this as well. The negative there, and again, they do a wonderful job, but because they don't have the medication background, sometimes they can't say, well, let's look at this one. And I'm in the office with your doctor. I'll see if it's okay to just switch to this other product, if he's okay with switching, if everything else looks good for the plan.
What pharmacist should they go to ask these things? And
I
if they
think asking retail pharmacists, they may be able to help. I know that there are some clinical pharmacists, like in maybe endocrinology offices, or if there is a primary care pharmacist in primary care practices, that might be a good resource. There are, asking around and seeing who might be available to help would be a great idea. And there should be more opportunities for that. Obviously, I don't charge, and I know the SHIP volunteers at the Department of Aging don't charge. But maybe if they don't have a pharmacist that could sit down and look at all their regimen, getting maybe the initial done by the SHIP office, and then taking that information to the pharmacist and saying, do you see anything that might be able to be different? Might be a way to do that. Retail pharmacists could play a huge role in this, but I hate to say, oh yeah, go to your retail pharmacist, because we know how busy they all are. I allot an entire hour to sit down with folks, and I don't just look at the financial component. I take that as an opportunity to look at their entire regimen, look for drug interactions, look for side effects, look for duplicate medications. Just use it as a comprehensive appointment to look not just at their cost, which obviously everybody's interested in, but the overall regimen as well.
So, are there any misconceptions or pitfalls that you're already seeing as patients start asking about the 2026 coverage?
I think that what a lot of people, there are three components of paying for your medications. The first is the monthly premium. So every plan has a monthly premium. Some of them are zero and some of them are over $100. So picking a plan, sometimes people will pick it based on the monthly premium. Then there is the drug deductible, which can be anywhere in our state from zero to the maximum, which is a federal number of $615. Many of my patients do not have $615 at the beginning
I'm
of
saying.
January. Exactly. So that they're looking at those smaller deductibles, but what happens there is then they have this huge monthly premium.
Right.
And then if their drug's not on formulary, the big thing is looking at Medicare.gov, which looks at all of those components, the cost of the medicines, which is what you pay when you walk into the pharmacy, the monthly premium, and then the deductible, and looking at it all and seeing what you can do. Now, there is a monthly savings plan that came out last year where you can spread the cost of your medicines over the year. I had nobody in it last year, so I'm not familiar with it. But in theory, it would be if they were spending $2,100, if all their drugs were on formulary and they spent the max of $2,100, then they could spread that out over 12 months, and that makes it more palatable for a lot of people. So, but to be honest with you, I haven't had any experience with that, but it's great in theory, but I never had anyone do that last year.
So,
Now,
but
this year it
here's
might
the
be.
thing, though. If you have to spend $2,100, that's like you have to spend $175 a month, and
Yes.
sometimes people just aren't on that many drugs. Maybe that's why you didn't have a lot of people.
Exactly. And there are a couple things that I look at when I do that. And this is kind of a state by state, maybe even a county by county thing, is that in our state, we have a senior prescription drug assistance plan, which takes I mentioned the monthly premium. It will pay if people qualify. And as a couple, you can make $61,000 or less. So it's people with pretty, an okay salary income that if they make $61,000 or less, they qualify for this plan, and it would pay for all the monthly premiums up to $100. So those are other things I bring into play that we can try to reduce their overall cost. And other things is if they have very low income, they qualify for what's called low income subsidy, which is a federal program, which will reduce their costs by a large amount, which makes their brand name and their generic medications very affordable.
So, how can hospitals and community pharmacists work together to educate patients about their plan options ahead of time?
I think the biggest thing, and it would be great if a pharmacist could do this for everyone, but as we've kind of discussed, there really aren't avenues at this point in time throughout the country to do that. I think the biggest thing is going to the Department of Aging or their SHIP office or to a reputable company. And one thing I didn't mention is in the past, companies would do this for people free, but they used to get commissions for doing that. A lot of those commissions have been taken away for Part D. So less and less insurance brokers are doing this. So
Right. So
really,
they're not offering it because they don't make a commission off of it.
exactly. So the Department of Aging is probably the best bet. And I would love to say pharmacists could play a huge role. And if there is a pharmacist in the community that can do that, that is wonderful. And I do know a few throughout the country, but to say it's a common thing, I unfortunately can't say that. So just making sure they realize that they need to look at their plan every year, because one of the premiums that one of my patients was on, it was $40 last year. This next year it's $97, and that's a big difference. That's what $700 over the year more just in the monthly premium. So that is a thing to consider as well. And the monthly premium is not take the $2,100 that is accounted for. The monthly premium is over and beyond that. So they could pay $2,100 and still have $1,200 in a monthly premium for the year. So that's another thing to consider.
So, there's one thing that I came across, I guess it was a couple of months ago, an article that I saw where it said that now for 2026, if you don't choose a plan, you're automatically going to be put on a plan.
So that's typically what happens. And if they're on a plan now, and like one of the prescription drug plans went from 3 plans to 2, and I've had a couple people that the plan they were on is no longer there, so they just put them in another plan. So yes, so what will happen is you will be assigned another plan. Typically, it's going to be within the same prescription drug plan you're in. So like if you're with United Healthcare and your plan goes away, they're going to put you in a different United Healthcare plan, and it may
And
not be.
you'll have to stay on that one for a year.
Yes.
It's
So you don't, yes.
do something and make that choice.
Exactly. So if you don't make the choice yourself, they're gonna make it for you, and it may not be in your best interest.
And what are those deadlines this year?
So it's October 15th through December 7th every year, and then the plan begins in January 1st.
All right. So looking ahead, I want to get into a couple other questions that I have for you, just regards to pharmacy, unless there's something else you'd like to add about
The
Medicare.
the only other thing I would mention is that for a lot of my patients that have been on high cost medicines, the other component that I help them with, and that many physician practices will help with, is the patient assistance programs, where the drug company, based on a lower income or a certain threshold. Again, the incomes are pretty high. It's not like poverty level. They will allow you to get your medications free of charge from the manufacturer. Ozempic is a great example.
I've seen some of those types of things. Uh,
Yes. And
yeah.
unfortunately, Ozempic is no longer going to provide that service to patients that are on Medicare. So we are scrambling with all our patients that we have put on Ozempic through the patient assistance program. That's how they can afford it, to get them have an affordable insurance
I
plan
was
for
going to say,
next
don't you have
year.
to have an actual insurance?
Yes. Or to
Something
be
like
honest with you, we're switching to a different GLP-1, a different drug in the same family, obviously with the permission of the provider or the prescriber.
how many people are actually on that?
Um, so I'm a certified diabetes educator besides geriatric certified, and they really are, for my patients that have diabetes particularly, because Ozempic isn't usually covered for people with weight issues. There are a lot, and it really is an excellent product for people with diabetes, because it not only helps bring down the blood sugar and helps with the A1C, which is the lab work that we look at to make sure people are at optimal care from a diabetes standpoint, but it also helps with cardiovascular, and more they're showing also kidney benefits. So these medications can really make a difference in the overall health of people. So even though they're really expensive, they really have kind of become the standard of care for diabetes. So more and more people are on these.
Want to be overweight and diabetic at the same time, but so many people are taking this stuff for weight. Are there any negative effects for if you're not diabetic?
I mean, there are drugs. They have different products that are manufactured and indicated for weight loss. So Ozempic is usually for diabetes, and I think they got recently approved for, and I'm not exactly sure, for sleep apnea, I believe, and some
Oh, wow.
other, like I mentioned, the cardiovascular. But for weight loss itself, there's like Wegovy, and other products like that. And so they're the same chemical compound. They're just in different amounts, and they're for weight loss specifically. In the past, um, um, Medicare has not really covered those. And I looked at a Wegovy for a patient last week, and I haven't looked at all the plans, but it looked like for her, they're not going to be covered for her as well. So time will tell to see if they will end up being covered by Medicare. But at this point in time, it doesn't look real good. And I don't know for sure if there are any plans that are covering them.
Basically, because everyone's on it for weight loss and
Yeah,
not
if it's indicated for weight loss.
really.
Yeah.
So the people that are on it for weight loss are taken away from the people that actually need it for diabetes.
That's what some people with diabetes feel. I don't know if
Right,
it's true, but
right.
yeah. I mean, initially when there was a shortage, that was probably definitely an issue. But
Well, I mean, the
yeah,
cost.
yes,
Was it like $1,000?
yes.
Is that
And
for was that for 1 month or like 4 months or what?
I think it's, oh gosh, I don't know. I'm thinking 4 or 5. There are some plans out there, like you can go straight to the manufacturer, and it's now $4.99, I believe. There are so many different ways to get these products. And that's another concern that I work with people, because a lot of people are getting them from other countries
Uh,
and getting them online.
Well,
And
how do they do that? How do they go online and do that? Like, I don't
I don't know.
understand
The
how that
National
happens.
Board of Pharmacy has really said that you need to be careful with this, because we found that a lot of times they're counterfeit. They don't have the
Is that like those,
quantities.
like
Yeah.
her
Yes. And I don't want to speak against any one company, but they really need to be vetted out. And because, I mean, these are injectables for one thing,
Yeah,
and
this
they
is
could cause,
funny.
as with any medicine, they could cause great harm. And if it's not what we think is being administered, it could be really very harmful. Yeah, it can be a real concern.
Well, I
Yeah.
didn't mean to go down that rabbit hole,
No,
but
that's
that's
okay. And there was compounding going on in our community, where they're compounding the product. And again, the FDA, when there was a shortage, the FDA was kind of letting that happen. But now they're kind of in the Board of Pharmacy, and now they're kind of saying, hey, this isn't kosher anymore, because we have enough of the real product. And compounding, is under different circumstances than in a, manufacturing site.
correct.
There's whole different things that you just don't know what you might be getting into.
Because it's going to be made maybe
Yes.
slightly different.
And they're using different ingredients and, different preservatives, different,
You could
diluents,
be a guinea
all
pig.
those
No.
kind of things. Yes. Yes.
So, what do you think the next evolution of pharmacy and transitions of care will look like? So, especially with AI, which you and I talked about that at the summit, and digital tools becoming more common.
Yeah, I think there are some pharmacists that are kind of scared, but I think there's still that high touch. And I think we talked about that at the summit. I do home visits with people, and when you're in someone's home, you see things in a very different light. It comes together and you kind of understand why things are happening sometimes more. You may see a situation or, understand that they're having difficulty even just filling a pill box, those kind of things that as much as AI may help us with knowledge, it's not going to help us with just looking at the day to day and the more low tech things that might need to be done to make sure administration of medications is optimal.
Well, a lot of people, maybe if they're patients or caregivers that are listening, they're like, pharmacists coming to my house? Talk about that a little bit.
So that's the thing I like most about my job. And again, as I mentioned, I luckily get to work hand in hand with social workers and nurses. And we will go to a home, and one, you develop a relationship in a different way when you're in a person's home. And not that I go repeatedly. It's probably one or two times just based on the need, but it really helps develop the relationship. And because I'm affiliated with the primary care provider, I have that trust already. And they've already maybe seen me in the office before. They definitely talked to me on the phone. So it's not like some person that they don't know is just walking into their home. We already have established a relationship through their provider, which
Right.
I
But
think makes
still,
a
I
big
don't think
difference.
anybody listening has had a
A
pharmacist
pharmacist.
into their home. I mean, that's
Yeah.
literally unheard of. Like, I
Yeah.
love it though.
And I wish I could do it with everyone, although it wouldn't be obviously productive. But you have to pick and choose because obviously you only have so much time. But there are those people that this is not going together. We need to figure out what to do. And sometimes it's more social work, and that's when the social worker will go in, and we might go under the guise of looking at medications, and the medications may be fine, but there's a social issue that needs to be addressed that was kind of hard to identify. So it's not like it's happening every day for everyone, but I would say I go on maybe one a week, and it's kind of vetted out between me and the social worker or the nurse. You just have that phone call and things just don't sound right, or you can't really, I'll go over medications over the phone with people, and some people know exactly what they're taking, when they're taking it, the doses, and other people have no idea, and they're on multitude of medicines with multiple providers, and it's not easy for them to get into the office, and it's like, this might be the best situation to go into a home visit.
Right. Well, that sounds very interesting. I'd like to hear more about that and maybe next time. But
Yeah.
I have some question and this two more questions for you. If
Okay.
you could change one thing about how the healthcare system integrates pharmacists into patient care transitions, what would it be?
I think the most frustrating thing, and I'm sure you probably heard this at the summit, is that there's no pay structure for people that are clinical pharmacists. We have been tied to the product, and the product costs keep going down and down and down, where I know some retail pharmacists won't have some of the certain medications in stock because they lose money when they dispense them. And when that's happening, then how can you provide any clinical services? And nobody's ever put together that a pharmacist, you pay them for their knowledge. You're always paying them for a medication. So having that provider status or some avenue where pharmacists can be able to bill for their knowledge and for the non dispensing role, I think is the one thing that we really could benefit from.
All right. And finally, what one takeaway you want our audience to remember about the pharmacist's role in safe, effective transitions of care?
The biggest takeaway I would say is it's not just about transitioning from with what we've talked about today, with transitioning to different sites. Like we a lot of times think of hospital to home as transitions of care. I really see Medicare and when the changing plans happen as also a transition because the formulary is changing, the cost of the medicines. And there can be barriers in care if we do not look at that every year. So looking at that can be really beneficial from a transition transition of care standpoint as well, to make sure you're transitioning the next year with the best medications you can be on based on the cost of the medication and the plan that you choose.
Well, Trisha, I want to thank you for spending this time with me today because I learned a lot, honestly.
Well,
I
thank
love
you.
these type of interviews because I learn so much. Like every time I do an interview, I learn more things that I had no idea.
Well, as I mentioned before, you're very gifted at this, and you make it easy to be interviewed. So
And
thank
as I
you.
told you, y'all gonna make my head so big, I'm not gonna be able to get out of the house. I have to water my plants. Right.
Thank
I
you,
want to
Miss
thank
Mary.
you. And we'll definitely have you back on some more, Trisha, in the future. We've got a year of this right now. So looking
Okay.
forward. Anything you would like to add?
No, one thing I was thinking when I recommended the Medicare D, just because of the time frame, it was really important. But I think, talking to some of my coworkers would be really beneficial to see how their opinion is of how pharmacists work with them and their role. And maybe if not my
Yes.
coworkers, other people who have other disciplines that they work with.
Well, that's what InTalk does. We work with,
Yes.
we're multidisciplinary. And right now we've just been lucky enough because I guess y'all aren't busy enough because the pharmacist seems to be having more time for me. No, I'm kidding. But yes, definitely we are going to get into more discipline as we go. Probably after this show, we will probably have some case managers and
Awesome.
see how they integrate with everyone as well.
Yes, yes. I think the team pharmacy has unfortunately been a profession, at least within my career, that a lot of times silos itself. And it works so much better when you have other disciplines working alongside you.
Well, other disciplines, let me tell you, from my 15 years at Intalk and working with doctors, nurses, case managers,
Yes.
social workers, they all silo themselves. And
Okay.
that's
Well, that's
why
good to know.
Intalk, that's why we speak about it's a team, the team effort, the teamwork. The team isn't like we were talking on our meeting the other day. You can't put your healthcare providers because when you think about that, people only think about, okay, my doctor, my
Yes.
nurse. They don't think about how many other members are on that team. They're multidisciplinary. See what I said when I said I can't say that word?
It is a long word, but very important.
Yeah, I
But
agree.
thank you so much again. I appreciate the time
Yes,
and
ma'am.
the
Thank you.
opportunity.
Well, that wraps up today's episode of The Relay. A huge thank you to Dr. Trisha Cash for shining a light on the real challenges patients face during medication transitions and the powerful role pharmacists play in preventing errors, reducing costs, and supporting better outcomes. As Medicare Part D evolves and open enrollment gets more complex, patients need trusted guidance more than ever. And as Dr. Cash reminded us, collaboration, communication, and integrating pharmacists into the transitions of care team isn't optional. It's essential. If you found this conversation helpful, share it with a colleague, subscribe, and stay tuned. We'll keep bringing forward the people and ideas that are improving patient care, one transition at a time. Thanks for listening. We'll see you on the next episode of The Relay.